everybody. Thank you for being here. My name is Valeria Ferrari. I'm the General Manager of Teethan. In this session, held by Dr. Antonino Cacioppo, we will see an interesting use of Teethan during the daily practice, especially with a prosthodontic focus. So just a few words about Dr. Cacioppo. He graduated with honors in dentistry and dental prosthetics at University of Palermo. He has also a Master of Implantology with Dr. Rapani in 2007. He has also a PhD in odontostomatology in 2011. And he also did an advanced training in surgery and guided implantology at University of Genova. Since 2008, he has been specializing in 2D and 3D dental radiographics, prosthetics, and CAD/CAM design, and for dental practices and guided implantology. So he's a really digital dentist, and is author of several international publications, and is also contributed. He has also contributed to publication of specialist book and collaborated with the International Journal of Clinical Dentistry. Since 2015, he has been a lecturer of Master of the second level in complex oral rehabilitation at University of Catania. And in 2017, he has been professor and lecturer in prosthetics at University again in Catania. So as always, our key opinion leader, especially Dr. Cacioppo, that was one of our first key opinion leader, is representing the perfect integration of scientific publications, scientific researches, activity in universities, but also is running a clinical practice. So it knows your need and your pain during your daily work. So during this session, we will see how you use Teethan in the daily practice. He usually defines his approach as a Teethan guided approach. That is a really interesting name. And we will see how Teethan can help him in evaluating the occlusion values to a better understanding of the occlusion, and also in order to check if our restoration are going in the right direction, they're well accepted by the patient. So I will not lose more time. Thank you again, Dr. Cacioppo, for being here. You know that for me, it's always a big pleasure asking you to do these kind of webinars. And if you have any question, please write them at the end, in the chat, and I will read them at the end of the webinar. Thank you again.
Thank you, Valeria. Thank you to all the guys from Teethan company. And thank you all guys from the US to be here today. It's a great pleasure for me. I'm sorry for my English, but I'm from Italy, so that's it. It's not as good as the Valeria English. Today, it's a big pleasure for me to be here, because I will talk about a device that I love very much. That is Teethan, this little device here. We will see, basically, we will see three different, we will have three different focus today during this webinar. Basically, what is Teethan, okay, and how does it work, and so on. The probes, we will see a little tips and tricks to use in daily practice, like I do. We will see also, of course, the second point is how can we use daily, because that's absolutely the secret, okay, for every technology to use daily, okay, in our daily practice, in every patient. 100% of my patient, or 99% of my patient, I use all kinds of stuff. I'm a digital dentist, but absolutely I love to use this little device here, the Teethan. And of course, we will have a big focus on prosthodontics, okay. I'm a prosthodontist, but I also work as a general practitioner, because I live in Palermo and I've got my own private practice here. So let's start with the first big point. What is Teethan? Okay, Teethan, it's a little device to analyze the occlusion of the patient. through the muscles. Okay, it's a strange approach. It's a device to have an electromyography examination of our patient. Is nothing new from this kind of from this point of view, okay, because there are, I don't know, 50 years of literature about electromyography and electromyographical approach to patients. But to me, it was okay. I started to use Teethan maybe 6 years ago, and nowadays I've got 2 devices, my office, and all the dentists that works with me, they use it daily, okay. And Teethan is absolutely different from any kind of other electromyography, okay, from anything previous, because it's easier than ever, okay, and then everything else. It's faster than the previous approach to electromyography. It's totally wireless, no wires at all, and to me it's absolutely a good thing. And it's also repeatable, reliable, but the big thing is that it's easy to use. To me, this is the real trick to daily digital practice, okay, and to innovation, to the revolution in dentistry. And another really important thing to me as a practitioner, as a general practitioner, but more above all as a prosthodontist, is that all the values, because all the parameters that comes from the software of the Teethan, and there are a lot of parameters, we will see them together, but all the parameters are referred to occlusion. And to me, this is absolutely a big change, okay. Basically, we have 4 probes, okay, totally wireless, and we can use these 4 probes on 4. This is the basic version that I love, okay. There is another big version with 6 probes, but you can start using more and more probes. But to me, the trick, the point, the focus, the big focus is to have an approach as simple as it could be, okay. So 4 probes, 2 on the temporal muscles and 2 on the masseters, okay, muscles, and that's it, okay, as simple as it. And what Teethan does is to have it's like a sort of weight scale, okay, that measures the balance between one muscle and another. Okay, for example, the first value that is named POC, okay, this one, let me underline, okay, this one, it measures the balance between the temporary of the left side and the right side, okay. The POC, the second POC between masseters, again, from the left, between the left and the right side, or the balance between 2 couples, okay, and that's it. There are a lot of values. That's not a lot, but okay, a number, okay, of values, and we can measure with parameters, okay, with data, with numbers, the barycenter, okay, between the anterior and the posterior of the occlusion, of occlusal plane. We can measure the balance to have a torsion, okay, it's like a sort of cross balancement, and the asymmetry, and of course, this is anatomy, nothing new. Of course, everything that is related to the masseter muscle is related to the posterior of the occlusion, okay, molar or premolars, but not so much, okay. The the distal side, okay, the posterior side of the mouth. Everything that is related to the temporal muscle is related in the intraoral side on the occlusal plane to the anterior of the occlusion. It's an absolutely very simple approach. Okay, it's a schematical approach, and we can image. It's like this image. We can imagine that we have two couples on the anteriors and two couples on the posterior of the occlusal plane, both on the upper jaw and the lower jaw. It doesn't matter, okay? Because what's matter is the contact, okay? Are the contacts between the upper jaw and the lower jaw, and everything that interacts with this contact, like a pre-contact, okay, or under occlusion in one point, or missing tooth, and so on. It unbalance this kind of balance. Okay, sorry for this little joke. And one big value to me is the impact. The impact is the sum of all the activity from all the muscle, the two temporals and two marseters. And this kind of value, this kind of number, okay, the impact value is related in such a strange way. Okay, I discovered it in in years of clinical approach and analysis through Teethan, and watching the mouth of my patient and the occlusal point. Okay, but this kind of values, the impact in particular way is related to the vertical dimension. That is absolutely mind-blowing for a prosthodontist, but in general for a dentist. Okay, having the possibility or the ability to measure, okay, a value that is related to the digital vertical dimension. The vertical dimension. The digital one, okay, is another point, or we will see it. But how can we use this approach in everyday practice? Daily practice is absolutely made of single steps, and the easiest one are the most important one. I took 100% of my patients intraoral digital impressions. Okay, I use a lot of intraoral optical scanners. I've got 8 of them in my private practice, and 100% of patients are undergone of a digital impression. And I use a lot. Okay, you can use also a physical impression material. It's absolutely the same. It's not the same, but you can use, okay, with Teethan. It's not a problem. And you can use the paper for occlusion analysis, but I love to use digital papers to have a more precise and optical evaluation of the colors, pseudo colors, okay, that are related to the contact points, okay, between the upper jaw and the lower jaw, the meshes, and so on. But it's like a sort of mysterious things. What contact points are valuable, are more valuable, are more important than others? Okay, this is absolutely an example. Okay, that's one of the mouth of one of my patients. Okay, a generic patient. During a first visit, it's absolutely impossible to me during a first visit or during a prosthodontics. It is absolutely the same to see a difference. Okay, of course I can see a difference in color with contact paper, but to see a difference in the value of the contact points. Is this one more important than that one, or that one, or that one? Okay, is it important for the muscles? It's a clinical approach, nothing new. And with the Teethan, the amazing thing is that you can literally see what's happening to the muscles and related to the occlusal plane. Okay, so the Teethan gives me some more news about my patient. Okay, 100% of patient, then that's the trick. And if we analyze again the same contact points as before, but with the Teethan parameters on the screen, only 5 seconds, we got 5 seconds in between a patient and another. Okay, we can spend this little amount of time, and we will see that there is an imbalance. Okay, here I underline for you on the POC, the masseter POC, on the right side of the patient, that is this one. So these are absolutely not good contact points, okay, because there is a pre-contact and there is a torsion, okay. This is like a tendency, okay, and there is an I values or impact. The I values sometimes very often is related to the loss of digital vertical dimension, okay. And it's very important to me to analyze, to see. The more I see it, the more I have a diagnosis, the more I can talk with my patient about the therapy and so on. And so the trick is to have 100% of the patient analyzed through this kind of approach that is not new, but nowadays it's absolutely easier than the past. It's absolutely faster than the past, okay. And this is the big revolution, okay. It's another first visit, okay. My protocol, I've got some photos and videos during the first visit. I've got my anamnesis, of course, my examination, okay, under microscope. I've got this kind of approach, and I register everything, okay. I record everything, okay, with my camcorders, with my screen recorders and so on. And I've got digital impressions. I've got 2D X-rays imaging, 3D imaging for 100% of my patients, and of course the Teethan analysis. Okay, I want to see the muscles. I want to ask the muscle something that I cannot see only with my eyes, okay. And if you have this kind of approach in 100% of your patients, something changes, okay. Something changes in you, because you have got more data for diagnosis, more data for to talk about therapy with all of the dentists that work with you, with the orthodontist in this case, and we know more about the mouth of our patient, okay. It's nothing absolutely revolutionary, but it's revolutionary, okay. This kind of approach totally changed everything, and this is a protocol, okay. The trick is to have this kind of approach 100% of the time, and the same in prosthodontics, okay. Let's talk about prosthodontics. When we could use the Teethan in prosthodontics during the procedures of the prosthodontics. In every single procedures. I mean, there's not a big secret about Teethan, okay. It's only useful to see something more about the contact points. And the contact points are very important in prosthodontics. So say, okay, before starting a therapy, okay, when you have got your diagnosis, to analyze an old prosthodontic, an old prosthesis, okay, both for the removable prosthesis and for the fixed one, both on the teeth, both on implants, And during all the procedures, when you have temporaries, okay, to check your temporaries, or if you have a before the temporaries, if you have a works-up, okay, digital works-up, maybe you can print the digital works-up and you can analyze the contact point of digital works-up, or the physical one, of course, and you can test the raw structures before glazing, for example, or you can test during the last visit of all the prosthodontic protocol, to avoid the risk of fractures, okay, on the ceramics or so on. And let's start seeing some exact examples of every single steps, every single prosthodontical steps, okay. This is again a first visit, and during a first visit, I as a prosthodontist, I've got my eyes on all prosthetics, okay, 100% of the time. If I see an old bridge or two bridges and the crown, two crowns, okay, in this kind of patient, okay, the first question that there is on my mind is, are those prosthetics good? Okay, I don't mean, I'm not talking about the color, the shape, everything is important. If you have got some caries, okay, of course, or detachments, everything is important. But what about the integrity of porcelain, of ceramics? But what about the height, for example? What about the contact points? Are them good or not? And in this case, this patient have got a TM joint disorder, okay? And to me, they were related to old bridges, but it was only my opinion. I needed some data, okay, to talk with my patient, but also to talk with myself. It's absolutely the truth. So I undergo with my patient, of course, 2D imaging, 3D imaging, the intraoral optical scan to have my digital models, but of course you can use the gypsum. It's absolutely the same. It's a protocol. It's the same approach ever. Okay, and take 5 seconds of your time or 1 minute and have a Teethan examination. And in this kind of patient, I saw an impact value that is the last one, this one, okay, that was the 60% over the normal value, okay. It means a very, very high value of impact. And also we've got an unbalance between the left and the right, both on the masseters and the temporals. Everything is on the left side, okay, it's unbalanced on the left side. The barycenter is absolutely on the anteriors. And this patient has got a deep bite, okay, so it's absolutely okay to have an anterior barycenter and the torsion. And I want to analyze by means of the Teethan and by means of the contact points paper, okay, or digital papers like I do, the meaning of these values, okay, the meaning of the contact papers, okay. You have to analyze to have a good diagnosis, and you cannot have a good therapy if you don't have a good diagnosis. This is my approach to dentistry. So to analyze everything, I need these two systems, okay, the models and the Teethan, and of course my eyes, to analyze all the parameters and all the values, all the colors. And this is very strange, but when you have this kind of approach, everything changes, okay, in a minute, because this time I know that this contact point, okay, over this one, it's it's more important, but not so. And this contact point is related to the anterior barycenter, and this contact point is related to this this kind of unbalance. Okay, everything on the anterior and the left side of the patient, and everything is suffering because of the TM joint disorders, the pain of the patient on the left side, the more, and the impact is very high. So maybe all those prostheses, well done prosthesis, okay, but could be more high, okay. And this was my approach. It was absolutely an attempt. I tried to simulate. I love to simulate before starting a therapy, to simulate a therapy, and I use it in this old case. I used a digital approach, but you, of course, you can use an analog approach. And I've got some overlays to simulate the increase of vertical dimension. And after this kind of increase, okay, no prep overlays in PMMA to increase the vertical digital dimension, I measure the occlusion again with Teethan, okay, not only with the contact paper, not only with asking my patient if it was good or not, if it was common or not, and it's absolutely okay. But I want some data. I want some parameters. This is a big change, okay? And I saw that after this dramatic change, it's absolutely very uncomfortable at the beginning for my patient, but after 3 days, everything was absolutely perfect, and the pain get lower, and everything about TM joint disorders get lower, and so on. And the Teethan gave me the it's like a sort of confirmation, okay? It's like a sort of okay, you are on the right way. That's the way, okay? If you are a prosthodontics, you can follow that way. And this is what I did, okay? I increase in this image, you can see all the provisionals on the lower jaw and the new bridges on the upper jaw, and in every single step. But of course, I could propose to my patient also an orthodontics approach, but I'm a prosthodontist, so my focus is there. And of course, my patient had some old bridges, so it was the right thing to me to propose, and he accepted, okay, and everything went the better way, okay. But in every single step, I mean, I'm not perfect. Any one of us is perfect, no one of us, but to me it's like a sort of confirmation, one step after another, okay. This is Teethan to me. Another case, this was the case as a case of is evident, it's clear, it's a deep bite, a very deep bite, okay. And the same approach, 2D imaging, 3D imaging, intraoral examination, clinical examination, you have to touch your patient. I try to have a good clinical approach, but this kind of situations, you have to decide to increase the vertical dimension, okay. It's not easy, okay. You have to increase, but how much? This is a good question, okay. And when you try to simulate, of course, you have got your models, gypsum or digital ones, doesn't matter. And of course, your Teethan examination during the first visit, because you know that it will be a prosthetics case. It's absolutely necessary to have this kind of increase. And if you want, you can also have your orthodontics, your periodontist, absolutely, your endodontics if it's useful, or your I don't know, implantology, different approach. But this is prosthodontics, okay? And the Teethan gave me some more data, some more news about my patient. The POC of the temporals was unbalanced. The masseter ones, they are good. The bicenter is, of course, on the interiors. There is a little torsion, and the impact values, they were absolutely higher than anything I saw before this case. I simulate this kind of increase. This is an old version of one of my softwares. This is the CEREC one, where you can use any kind of approach, also the analogical one, absolutely. When you simulate everything on a PC or in the labs, it's not the same to have a real change in the patient mouth. So you need to check in the patient mouth, and this is my approach again, to have a digital workshop, and in this case, no prep overlays in PMMA. In this case, I made them in my office. Okay, I've got 3. At that time, I only had 2 milli machine, and nowadays I've got 3. But I also have some 3D printers and some other stuff that you can use to have the provisionals, okay? And I put them in the mouth of my patients, and I tried again another minutes to spend about Teethan examination, and I tried again. And I saw that the impact value absolutely decrease, okay, when you increase the vertical dimension, okay? Occlusal vertical dimension is absolutely related to this kind of parameter. And of course, you need also to rebalance everything, but you need time. You need to spend more time. And I saw my patients for 90 days, sorry. After that, every 2 weeks, I have a Teethan examination, and of course my contact paper or digital contact paper every 2 weeks. And after a while, everything seems to be steady, to be absolutely repeatable. And that was the time, the T0, okay, 0 time, that was the time to start all my therapy, okay. But it's absolutely the same with daily cases. When you've got 1 crown, you have to do 1 crown on a teeth or a tooth, sorry, or on implants. It's absolutely the same. Or 2 crowns, like this case, and you want to evaluate how many contacts do you want, okay? It's not only related to our eyes, to the contact paper, it's related to the muscles of the patient, okay? We cannot decide the contact points. Of course, we studied the contact points, the regular, the normal one, but every single patient has got its own anatomy, okay? And the muscle can teach us how many contacts, okay? And if the contacts are balanced or not. And this is another example, okay? When you have the provisionals without, on the left side, without the teeth, without those 2 first molars, okay, of the lower jaw, without them or with them, everything changes. Very, very little changes, okay. And if you want to try different heights, you can do with provisionals. If you want to try to because it's not absolutely, it's not on off. It's not the first and the last. Okay, this is a webinar, so I've got no time to have all the steps of a treatment. But trust me, it's not one step. You have to try, you have to rebalance, you have to increase or decrease on the right or the left, even for 2 single crowns, because sometimes this is absolutely what I did. Okay, this is the first attempt, was not good, the second attempt, the third attempt, and finally I found not my way, but the best way to have those contact points for the patient. Okay, on implants, it's absolutely more difficult than teeth, to me. Okay, this is my opinion, but you can try, and you can evaluate before the end of the therapy. It's absolutely useful, because if you had this kind of balance, you have less fractures, you have less failures, okay, of your treatment. I absolutely assure you. And of course, with two bridges. Okay, when you've got, how many patients do you have with 2 bridges? These were 2 digital bridges, digital walks-up on implants. Okay, implants on the right and the left, and I wanted to try to have the better balance possible for my patient. Okay, because every patient has got different anatomy. Okay, another case, when you don't have at all, like this patient was vertical dimension. Okay, you have to start, and when you start, okay, this is prosthodontics, and it's the same since 100 years maybe. Okay, okay, the bite blocks registration in WOX, the easiest, but also the most difficult thing in prosthodontics, because you have to rebalance everything from zero, starting from zero. And in this case, you can have, of course, your plane, okay, your guide on the outside, your eyes, your lines, okay, on the face of the patient, and your parameters from the literature. Everything is okay, but why not to ask what the muscle of the patient think about that vertical dimension and that those contact points. Okay, it's as easy as it is. Okay, and you can use, even during this kind of procedure, you can use the Teethan. It's absolutely amazing. Okay, it's easy, and it's fast, and it's reliable. You can use in several appointments. Okay, you can use in several different ways. Of course, I prefer to have a digital way. Okay, that's my way, but it's not necessarily your. And when you transfer everything to the lab and start, these are 3D printed, okay? And when you want to check in the mouth of your patient, you have to check it with your eyes, with your contact paper, by mean of the movements, okay, the protrusion, the lateral movements of the patient, but also asking the muscles of the patient, okay? Because the muscles can tell us a lot of things, like this way, okay, the pre and the post, before and after, and before and after a check, before and after a walks up, and after that I went in guided surgery to have full mouth rehab on implants, both on the upper jaw and the lower jaw. Okay, I got my immediate loading. Okay, those were the temporaries. PMMA, it's a good material, and it's reinforced. Okay, I use PMMA on the outer and chromocobaltum on the inner, or titanium, or something else. And again, I wanted to check the occlusion, starting immediately, and after that, checking every 2 weeks. This is the time I use it, okay? And after 30 days, after 1 month, everything looks perfect. It's absolutely amazing. And you can start the end of the therapy if you want, or you can wait another month or 2 months. This is your protocol, not mine. It's not necessary to talk about that in this kind of webinar. Another example, when you don't have an occlusal plane both on the upper and the lower jaw, and you want to check, you need digital walks-up, you need walks-up, okay? You need physical walks or digital ones or 3D printed ones. I love the 3D printed walks-up, but I need to check. This is without anything. It's not normal, it's not an occlusion. You cannot evaluate nothing. You've got 2 points, 2 contact points, and you need the lab side. This is the virtual walks-up. You can check, you can have different shapes, different heights, different kind of numbers, okay, if you want, of teeth, the first molar, the second molar, okay, it's your choice. And after that, you need some physical, okay, walks-up. I use 3D printers, but it's my way. That's my way, absolutely. And after that, the physical walks up need to be checked in the mouth of the patient. That is the best articulator ever in every single patient. Okay, you don't need a lot of precise articulators. You need the patient to check everything. Of course, you can use articulators, why not? And you can check again, you can check, you can move the contact points, you can restart if you want. It's resin, okay, 3D printed resin, or wax, okay, if you want, or anything you want. And you can change everything, and after that you can go further. This is the temporary, okay, the day of the extractions of the upper jaws, the day of the surgery, implant placement, okay. And again, another Teethan examination. This is okay. Of course, after surgery, the patient is not okay, it's not 100%, but it's a data, okay, why not? And after 3 months, you start to manage the temporary and the soft tissue and the protrusive, and after that you can test some shapes. The implants were good, and all the data, all the parameters from the Teethan, from the muscle of the patient, everything is okay. The patient at that time had a good chewing activity, had a good muscle activity, and no TMJ disorders at all, no pain at all. That is very important to me. And at this point, if you want, you can start the end of the therapy. And we can see in this case, the end of the therapy, okay? This is an old case, very old case. The first one I did 100% from intraoral digital impression. This is an implant retained case. All the upper jaw needed to be replaced. To me, also the lower jaw, but the patient doesn't want that. It was a shame, but that's life, okay? I did some implants in guided surgery. I love guided surgery. I love to be as much predictable as possible. And these are the temporary. This is the temporary on the upper jaw, and also two implants with no temporary because there was a broke. Okay, it's absolutely everyday case. And these are the impression. This is 7 or 8 years old case, screw retained implants, prosthodontics or prosthesis, by means of intraoral digital impression. At that time, I didn't have my Teethan with me, but in the final step, I knew Valeria, and Valeria Ferrari from Teethan, and she absolutely blazed my mind. Everything changed from that time, and this is the final results, the final prosthesis, a good results, both from an aesthetical point of view and functional point of view. But what about contacts? Everything seems beautiful by means of photos, through photos in our keynotes, but this is not the reality. Okay, the reality is that sometimes we've got some fractures, some TMJ disorders. This is not an easy case. Okay, okay, look at that. That's the truth. 2016, it's the final step of my work, and at that time I start using my Teethan in this kind of procedures. And one of the first cases on implants was that I start analyzing my contact points. Of course, the lower jaw was absolutely the worst prosthesis on the planet. So it was only a matter of time, and after 2 or 3 years, we started lower jaw, and we start changing. So every kind of adjustment I needed was on the lower jaw, that old prosthesis, and and unfortunately, at the beginning, there was not a good balance. Okay, everything was absolutely unbalanced. But I started with patient to have, during one appointment, only one appointment, to have contact paper, okay, analysis, Teethan examination, my bars, okay, to change the contact points and change again and change again and again and again, looking on the Teethan values, okay? And at a certain point, everything was balanced. And from that time to now, absolutely no fractures at all. Absolutely no pain on the TM joint at all. Absolutely no TM joint disorders. It's not, I'm not lucky, okay? I don't trust in fortune or so on. It's a protocol, it's an approach, it's a parameters and evaluation, and it's a protocol. Okay, again, sorry for my repetition. And that's the starting point and the end. And again, a very old case. In that case, again, an implant retained prosthodontics, okay, on prosthesis on the upper jaw and lower jaw, guided surgery. Those were old protocols. I changed a lot of my protocols in guided surgery. At that time, I want to spend as less time possible, okay? And I preferred to have no flaps. But today, I don't trust in flapless. Today, I prefer to have a surgery, to manage the soft tissue. But I was younger at that time, and 6 implant on the upper jaw and 8 implant and 1 tilted one on the left, on the lower jaw. Okay, everything was crazy. And sorry for that final photo, because the patient occlusion was better than the photo. Okay, was better, absolutely better, but the photo was not perfect. Okay, sorry again, but from an aesthetical point of view, everything got okay, but multiple fractures again and again and again and again on the cuspid, okay, on the left side. We tried anything with my technician. We tried to change materials, to change the height, to change the contact point, to reanalyze everything. We were absolutely crazy. And again, at a certain point, I started to use this kind of approach to evaluate my mistakes, evaluate my failure. And this was the examination. Absolutely not perfect vertical dimension, not perfect at all, maybe missing in 8, and everything was unbalanced. Again, here, there is where I got my fractures. So the best approach to me at that time was to, of course, to change one of the occlusion plane. We chose the lower jaw. This was our choice. And we passed through a bite plane, okay, made by resin, not printed, because at that time I didn't have any printer, any 3D printer. Rebalance in 2 weeks or more. I spent 3 months to rebalance with this kind of bite splint. After that, when everything was good on the Teethan, I started to change with my technician, to change the ceramics, to change the height, the shape, the contact points. This is a photo before the glaze, the raw structure. It's absolutely one of the best moments to try your Teethan before glazing. And everything was good. Everything was comfortable for the patient. And starting from that time, no more fractures. Unbelievable. Trust me, unbelievable. No more fractures till now. I hope also in the future. And one last case, they were absolutely examples of what you can do, but your imagination is better than mine, of course. This is a complex case because it's a case that we started maybe 2 years ago in our office, in our practice, and with my colleagues. We started prosthetical therapy, and also an orthodontist. Was a complex case because we've got some abrasions, some loss, a very deep bite, very big loss of vertical dimension, loss of anatomy of the, and also aesthetics. Okay, not easy at all. And we already know that in these cases we can have a 3 steps. We can have a classical and predictable approach to the increase of vertical dimension. But what about the future? What about the TM joint disorders? Does we care about that? I care about that. Okay, it's very important for me not only to have good photos for literature or for congresses or for workshops or webinars. It's absolutely more important to have no pain for the patient, to have tables cases in the time, okay, in the future. So we started to analyze this case with a protocol, 2D examination, 3D examination, virtual contact paper, intraoral impression, 3D models, okay, everything digital. This is the Teethan during the first visit. It's very strange because I didn't expect to have this kind of Teethan data, okay? But this one, the impact very high, of course, is related to the loss of vertical dimension. But the other ones, okay, I didn't expect, but that's it. And we can use physical articulator on the labs to have a classic 3 steps, okay, from an anatomical point of view, the shape, the aesthetics, the color, the materials, everything is good. And you have to choose. I prefer to have my, of course, digital articulator, but also my patient, okay? And I can try, this is the trick of the digital, that you can try everything on the mouth of your patient, inside the mouth of your patient, and to use these free and better than anything else articulator, physical articulator, that is patient, okay? These are the simulation with lift gauges and all the steps, step by step. It's not easy at all, okay? I don't want to say to you that is easy. You have to try, you have to spend time, and after a while, this was absolutely amazing to me, this case, because I started to have an approach of asymmetrical increase of vertical dimension. Okay, how many times you did asymmetrical increase? Now I do, okay. And of course, guided by the Teethan, okay? Not only looking the shapes or looking the lab side, the articulator and so on. And look at that values, okay, in millimeters, absolutely totally different. We started step by step with a bite splint, okay, to have no a big change at the starting point, and after that I cutted my in three pieces my my bite splint, okay. I used those pieces to have the bite, okay, the occlusion in by means of my virtual occlusor or virtual articulator, by means of my digital impression, okay. And this is my room. I started working with a trusted, okay, verified on the patient new vertical dimension, a big change for a patient, okay, 2 millimeters or more or less. In this case, 1.7 millimeters on the right and 1.4 or 3, I don't remember exactly, on the left side, okay. So a big change, and those are the values from the Teethan, from the muscle of the patient, okay. And the patient was absolutely comfortable with an asymmetrical change and increase. It's mind-blowing. At that point, we started step by step with the walks up. Again, digital walks up. To me, this is my approach, not necessarily yours. Those were absolutely no prep at all, okay. Increase by means of these temporaries, okay. Both on the upper jaw and the lower jaw, we decided to separate, to divide the the increase of vertical dimension, half on, okay, or more or less half on the lower jaw and half on the upper jaw. And this is these are all the temporaries, okay, a new shape for the teeth, a new vertical dimension, new contact points, and we need time, okay. In these cases we need time, the patient need time. This kind of approach I prefer to use as a second step. In this case I prefer on the bite splint because the patient can chew, okay, and it literally changes everything, okay, because 24 hours a day, 7 days a week, 13 days a month, and so on, 100% of the time. And absolutely we increased a little bit, okay, maybe some more millimeters or sub-millimeters than we measured, okay. Maybe I remember 2.1 and 1.9, and after that we starting leveling with bars, we starting balancing, we starting modifying. I prefer this kind of approach to lower, to decrease step by step, and to try some changes, to try something that is comfortable for the patient and for the muscles of the patient, okay. This is after 3 months of work, and the patient absolutely changed. After that, we did with my orthodontist, we did an orthodontist, okay, an orthodontics treatment with the temporaries. We also, if we didn't treated the posteriors, only the anteriors, to close the diastema, okay, that was my goal, by means of clear aligners, okay. I don't remember if we used Invisalign or something else, it doesn't matter. And this is, those are the final temporaries, okay. Everything, of course, aesthetics, everything looks good, everything is comfortable, but what about the muscles? What about the function? What about the TM joint? Everything absolutely perfect. This is after the orthodontist, okay. Orthodontics can change something, okay. Not this kind of approach on the anterior side, but when you have got a complex case with a full orthodontics, you can have a big change in contact points, okay, and in height, and something new, okay, about from an occlusal point of view. But this is the aesthetics, these are the aesthetics, and these are the Teethan values. Everything is balanced, everything is comfortable for my patient. And we started last week to final therapy, and to have final therapy and to have our ceramics. I thank you for attention. I finished it.